Welcome and good evening or good afternoon, depending on which part of the country you're from. And thank you so much for taking the time to join us today for our first ever National Patient Summit. My name is Christina, and I'm part of the team here at LCC. Today, we have a really robust agenda for you today, and really encompassing people from coast to coast across the country, and just showing the depth of expertise that we have in lung cancer. And we hope that you will enjoy this evening. There'll be two opportunities for Q&A tonight for this event. And we are going to, as you get questions though, don't hold on to them, type them into the chat. You can find the chat in the bottom, kind of to the rightish corner. And then if you tap on that, then you can type your question to all, and then we can all see that and we'll be able to address them during the Q&A. For those of you that are uncomfortable listening to this or reading this in another language, then please go to the top left-hand corner, click down on the speaker link, and you'll be able to find do translation, simultaneous translation. So without further ado, I'm going to introduce our first speaker of the night, Dr. Stephanie Snow. Dr. Stephanie Snow is the current president of Lung Cancer Canada, and she's also a medical oncologist at the QE2 Hospital in Halifax, and associate professor at the Dalhousie University. So over to you, Stephanie.
Thank you so much, Christina, and thank you everybody for joining us this evening. This is one of many of our great activities during this November Lung Cancer Awareness Month. And so for those of you new or old to the organization, we thought we'd just start off with really grounding ourselves in what is Lung Cancer Canada and who are we? Ultimately, Lung Cancer Canada is an organization that was founded with the goal of helping to meet the needs of lung cancer patients, their caregivers, and to really provide the supports that they need. Since its inception, it's taken many different phases. A large role that we've attempted to meet is that of education through our patient guides. Thousands and thousands go out every year. Podcasts really allowing patients to have the most updated information about lung cancer therapies, opportunities, those types of things. We've also attempted to provide support for patients. We know that the experience of lung cancer, including many of the unique facets that are defined by things like lung cancer stigma, really are not shared with other cancer types. So we wanted to provide a safe environment where people could come together, get support from our colleagues, other patients, and we really found a unique role during COVID, which was a very stressful time, of course, for everybody, but lung cancer patients had a unique experience. So we were able to allow patients concerns, and we'll hear a little bit about that this evening, some of the specific worries during COVID, allow those voices to be heard, provide education and information, and then also to act as advocates, really trying to provide a voice advocating for early vaccination access for our lung cancer patients. It's become really a safe place, and we're really thrilled to have met one of our long-term goals to have a dedicated social worker. And we're going to hear from Elizabeth DeVerksen both tonight, and we're thrilled to have her here to provide that unique social worker perspective and support for our patients. We also have the unique financial supports through things like the Kayla's Angel Fund. And finally, we've been able to support research in lung cancer, summer studentships, and we also have our unique research award every year, the Jeffrey Ogram Award. So that's kind of who we've been. Now, if we can move to the next slide, you'll see that over this past summer, we did a listening tour. And I was thrilled to have people join us from coast to coast on beautiful sunny days, Friday afternoons. And we really had an opportunity to bring it back to those ground principles because we wanted to hear from patients and caregivers what's important for you. We're here to meet your needs. Can you please tell us what those are? So we started in Atlantic Canada, moved on to Quebec. I must admit that I was a bit nervous to try out my French, but I did, and I think it was successful. Then we did a Central Canadian, and then finally Western Canadian. And we definitely heard themes emerging across the country, but we also heard individual regional issues. And so this is an example of just some of the feedback that we got, and really being able to have this defined will help us to move forward to continue to meet your needs. So for instance, people talked about struggles of knowing about clinical trials, and if a clinical trial for their particular cancer at that point in time is not available for their own cancer center, can we have a central database for clinical trials? How do we find out what's going on elsewhere? And of course, Dr. Ho tonight from Vancouver is going to talk a little bit about that and participating in clinical trials. We've definitely heard from patients that they appreciated the education. So really affirming that important part of our mandate. Dr. Wheatley Price has now organized many excellent podcasts and hopefully many to come in the future. And we really hear that's been valuable. So we're going to maintain that as patients expressed the interest of learning about their illness. We heard about the disconnect between innovation and the newest treatments that you hear about coming out of these big health congresses in cancer and our healthcare system and what's available today. And so we're going to continue to act through our medical advisory committee to serve as a united voice to advocate for recommendations for provincial funding for these new innovations as they come out. We've really found it was helpful to allow our lung cancer patients to have their voice, because some may not actually get that in their day-to-day experience. And so allowing this to be a place where voices can come together with the volume of many has been a very important thing that we found very valuable. And finally, we've heard about the individual impact of lung cancer screening. This is a very exciting time as lung cancer screening is just starting to be rolled out throughout Canada. And one of our goals is to support that and trying to get equitable access for all Canadians. So if we move to the next slide, you can see that moving forward in the future, this has helped us to reaffirm and define our future commitment to really truly address inequality of treatment access and screening across Canada. We really want to strengthen regional supports and activities while also providing a national network. And finally, again, we're thrilled to have extra access to mental health supports by broadening our staff group to now include our trained social workers. So if you're interested tonight, you will also be able to go into a chat room just with Elizabeth, and we will hear from her later. So with that, I'm thrilled to pass back to Christina as we move on to the first formal session of this evening.
So, thank you, Dr. Snow. Our next speaker up tonight it's familiar to many of us here today, and it's our immediate past president, Dr. Wheatley Price. Dr. Wheatley Price, actually, many of you may have actually heard him. He is the host of our Lung Cancer Voices podcast, and he has also hosted our What's New series in lung cancer. So Dr. Wheatley Price is a medical oncologist at the Ottawa Hospital and is the associate professor at the University of Ottawa, and I'm turning it over to you.
Great, thanks, Christina, and welcome everybody again to the National Virtual Summit. I'm seeing a number of friendly faces there on my gallery. 2021. If you have a look at the Faces of Lung Cancer report, which we released a couple of weeks ago now, and you can get that on the website. There was a lot of discussion in that about the impact of COVID on all our lives and really how it's impacting lung cancer. But I wanted to move away from that. Dr. Zhao is going to cover sort of what we really need to know about COVID now after I've spoken. But I wanted to try and give a different, more encouraging message than the kind of, storm of coronavirus, and say that actually there's been a ton of good stuff happening in lung cancer in the past 12 months. There's been advances really across a number of areas, and so I'm just going to kind of run through a few of them, and I'm hopefully at the end of my sort of short burst here, you'll leave feeling encouraged that there are lots of new treatments, there are lots of new options, and we're seeing the results of that. Now, what's new in lung cancer? So Christina very kindly plugged that. So we do this What's New in Lung Cancer webinar series looking at a number of different topics. So I'm going to talk about, in the next 10 minutes, what's new in the last 12 months. But our next What's New in Lung Cancer seminar webinar is coming up just in a couple of weeks about radiotherapy. Terrific radiation oncologist, Dr. David Palmer from London, Ontario, and a global name, Dr. Corinne Fave-Fenn from the Christie Hospital in Manchester in the UK. So that'll be good if you want to get into that one. Okay, we go to the next slide. And lung cancer statistics. So just to set the scene here, lung cancer is the number one, I'm afraid for the wrong reasons. It's the most commonly diagnosed cancer in Canada. Actually 29,600 there is actually a slight tick down from last year when it was 29,800. It's the number one cause of cancer deaths. 21,000 people anticipated to die of lung cancer in this year, and that represents a quarter of all cancer deaths. So, those numbers are sobering. However, there is some progress, and if we move to the next slide, the breaking news from just earlier this month, when the Canadian Cancer Society released its statistics, is that the survival rates for lung cancer now are at an all-time high, and the increase in survival we've seen in the last 12 months is the biggest single-year increase that we've ever seen. So while 22% of people still being alive 5 years after a diagnosis of lung cancer is awful, it's not as awful as it was. And when I first started getting involved with Lung Cancer Canada, we were looking at 13%. And so 22% you can see is obviously a big plus. There's a gender split there as well. If we look at women, it's actually 26%. But, the sobering statistics, you can see that of the four main, most commonly diagnosed cancers, lung cancer, unfortunately, takes the life of more than the other three combined. But 22% is a great place for us to be historically, and the only way's up. All right, next slide, please. I won't belabor the point too much on stats. Here are the numbers. If you look at those graphs on the right, those are the common cancers and the incidence, so the number of people being diagnosed with cancer. So the blue is men. The solid bar is prostate cancer, so that's the most commonly diagnosed cancer in men. Lung cancer is the dotted line, which is sort of hidden now, and it's been steadily falling for decades, and now is around the same rate as colon cancer, which is the blocks. Down below in green, the solid line is breast cancer, so breast cancer is the most commonly diagnosed cancer in women, and lung cancer is the dotted line, and you can see it hasn't really been falling like it has in men, and maybe just inching down a little bit in the last 3 or 4 years. So that's something clearly to work on. Lung cancer rates now in Canada are equal between men and women. Over on the left, that table is mortality. So 44,000 men and 40,000 women die of cancer each year in Canada. And the list below in the small print, if you can see that, the top one there, unfortunately, is lung cancer, which is about a quarter of those. Okay, so that's kind of setting the framework. Let's move on to where the progress is coming from. So lung cancer screening, this is like super important, and it's been our number one advocacy ask at Lung Cancer Canada for a number of years, and this is why. So lung cancer screening involves a CT scan with very low radiation exposure, so they're called low-dose CT scans, and people who are at risk, which it generally does mean some factors around age and tobacco exposure, and we can talk about that in the Q&A if you like, but can really significantly change the stage at which people are diagnosed. So the green bars here in this graph represent what stage people are normally diagnosed at with lung cancer historically. And over on the right, 50% at stage 4, another 25% at stage 3. Stage 4 generally considered incurable, stage 3 curable but difficult. And only about 20 to 25%, if you add up the stage 1 and 2 in green there, have historically been diagnosed at those early stages where surgery can be a cure. With screening, which is what happened, the blue bars represent PanCan, which was a Canadian screening study, suddenly 75% of people now being diagnosed stage 1 or 2, which is curable. So let's move to the next slide. Can we get screening? That's the important question. Not everywhere, but compared to 12 months ago, a big step forward. So British Columbia was the first province to announce they're going to open a screening program. That'll be coming in the new year in 2022. And then Ontario kind of came up from behind. They had a pilot program and they've turned that into a formal, like, here to stay program. So that's now starting to spread out across Ontario. And then Quebec made a big announcement about starting to develop a program earlier this year as well. So now Ontario, Quebec, BC are moving forward. Other provinces, of course, need to follow. And we're putting a lot of pressure now, of course, to make that happen and give this an equitable access to all Canadians. But great progress in the last 12 months on screening. Okay, next slide, please. Okay, testing. So we've covered statistics, they're getting better. Screening, that's rolling out. What about testing? We need to know now, for anyone diagnosed with lung cancer, we need to know that, like, the fingerprint of the cancer, and that involves quite complicated pathology work to identify all of these different mutations. And that pie chart at the bottom is meant to represent, like, there's lots of different slices, lots of different subtypes that we need to be able to identify to point people towards the right treatment. And the testing itself is complex, but that is becoming more standard, more widely available, and importantly, it's being paid for. So Ontario, the province that I'm in, made a big announcement just a few months ago that they are going to provide funding for what's called NGS, or next generation sequencing. So this is the test that can identify all of these subtypes in one test. And these machines are pretty cool. And so there's the cartoon. That don't mistake your Nespresso coffee machine, it's actually a next gen sequencer. So that's good news. All right, let's go to the next slide, please. Right, treatment advances. So I gave you a sense of that pie chart, that there's lots of lung cancer subtypes, and there's been advances really across a lot of these subtypes in the last 12 months. So let's go to the next slide before I get yanked off by Christina to keep me going. But so small cell lung cancer, it's an aggressive subtype of lung cancer. And it's about maybe 1 in 7 lung cancers of this type. And we've started now being able to give immunotherapy together with chemotherapy for this group of patients. And we've learned that that improves survival. It's not publicly reimbursed yet, but it is available through some access programs. And similarly, mesothelioma, which is not the main topic for us at Lung Cancer Canada, but it is a cancer in the chest, of the lining of the lung, commonly associated with asbestos exposure. Now we know that immunotherapy for mesothelioma, also very effective. So for both of these situations where we're bringing immunotherapy to new populations, we've had positive results of trials in the past 12 months, and we've had these treatments steadily make their way through the fairly complex Canadian regulatory system. So they're not publicly reimbursed quite yet, but they're getting to that point, and we should see that in 2022. In the meantime, the relevant companies are actually providing the drug free of charge. Okay, next slide. Right, so non-small cell lung cancer, we talked about small cell and mesothelioma. Non-small cell is the big piece of the pie. That's probably about 80 to 85% of lung cancers. And now, you know, through this testing, this next generation sequencing, the fingerprint, we're identifying all of these different subtypes. And the great news for patients with lung cancer and their family members is that more and more of these subtypes now have treatments. We call them targeted treatments because it targets the specific abnormality that we identify in the cancer. And we're seeing more and more treatments either funded or approved or positive trials or making their way through that regulatory system. So if not immediately available, we can see it coming on the horizon. If we move to the next slide, this was, I'm not going to bore you by reading this to you because that would be really tedious for you all to have to listen to me do that. But there's 2 slides here. We'll just go through them, you know, briefly. But these are all of the changes that we've seen in the past 12 months for some of these targeted subtypes, but also for immunotherapy. So, for example, that top one, atezolizumab, is an immunotherapy drug. And we're now starting to see that that might be effective for people who've had those stage 1 and 2 lung cancers and have had surgery. So that's something that we're looking to see that's currently being reviewed. And then if we go down, Brigatinib is a targeted therapy which received approval this year. Cemiplimab, the next one, is a new immunotherapy, so it's another option which is just in the regulatory process, received Health Canada approval just a few weeks ago. And then Dabrafenib Trametinib for a rare subtype called BRAF, that's received approval. They're just negotiating the prices at the moment. Durvalumab, that's an immunotherapy. That's the small cell lung cancer that I was mentioning. That's working its way through. Entrectinib for a rare subtype called ROS1. Larotrectinib for a rare subtype called NTRK. That's like one in 1,000 shot, but it's a really good drug if you find it. We've got it now. So all of these things are making good progress, and we can see on and on and on. Lorlatinib is another ALK lung cancer drug. Lurbinectedin is a small cell lung cancer drug. Nivolumab, ipilimumab is a combination of immunotherapies that we can give with a short course of chemo in some lung cancers. Osimertinib is for the EGFR subtype of lung cancer for people who've had an operation. Selpercatinib, you've got to remember these, there's going to be a quiz later. This is for a rare subtype called RET. That one's coming. Sotorasib, this is a really important drug because it's for a not so rare subtype called KRAS, which might be 10 to 12% of our lung cancer population. And we've never thought we could have a drug for this, but now we do. And finally, Tepotinib is a rare one, another little subgroup called MET. But that's kind of the end of my talk. But what I want to kind of give you the message of is that all of these new subtypes, these rare subtypes, have treatments that we're getting approved and are coming, or in the not so rare subtypes where we're using immunotherapy, there's new options, or small cell lung cancer, or mesothelioma, et cetera, et cetera, et cetera. Add that to the better testing, the better staging, and the screening. And we are looking, we're looking at some very genuine hope that we're going 13%, 19%, 22%. And, you know, I don't know where we're going to hit, but it's going to be a lot higher. Right, Christina, I'm done.
Thank you, Dr. Wheatley Price. And as Dr. Wheatley Price was mentioning, there really is hope, and to help us bring hope here and make hope a reality. When we make a call out for patient and patient voices during the time when we ask for public reimbursement, we really encourage you guys to speak out and share your experiences, because that has really made a difference to us in our efforts as we go for public reimbursement. So next up, we have Dr. Kevin Zhao, who's going to talk about COVID-19 and what we need to know now. Dr. Zhao is an adjunct professor at the Université de Montréal and a hemato-oncologist at the Hôpital du Sacré-Cœur de Montréal. My French is awful, pardon me for that. He's also part of the programs committee at LCC. He was on the front lines of treating COVID-19 and also was a new dad during that time as well. So I now pass off the mic to Dr. Zhao.
Your French is excellent, Christina. I have nothing to say. And I've been a dad twice during COVID, so that's my little thing. So thank you very much, and thank you very much for everyone to be here tonight. I want to say before I start, because I have a couple of minutes, because Paul was a little bit quicker than I thought, that I'm both humbled and honored to be presenting tonight, because I think these are the kind of events that I think are really important. Bringing people from coast to coast with lung cancer is hard to do, and I think we've done it tonight. And I'm really proud to be among you. So that said, I'm gonna switch to my main topic, which is COVID. And for those who may or may not know, I've already spoken about COVID in previous events. As Christina said, I've had the unique experience of being on the front lines in the COVID wards. And so I have a unique perspective, but I think after 2 years of talking about COVID for all of us and hearing about the news, I think we've all sort of are experts about COVID. So I'm going to try and tailor this presentation to what I think is pertinent for you. And if there's anything that I'm leaving out, and in 15 minutes, there's certainly not a room for everything, we can chat about it at the end. So here's some things I won't be talking about, and certainly I'll try and stray away from anything of the crazy notions that we hear on social media. The other thing that I'm going to try and stay away from is, we have different policies from province to province, and some make sense, some really don't make sense, and I think I'll leave that to more smarter people than me. Next slide. So, it's funny. I find that the last 2 years have been going at warp speed, and it's just 2 years ago we were starting to talk about a virus on the other side of the world, and who knew that it would completely turn our lives upside down and cause all the havoc that we've been living in the last 18 months. Next slide. And when we look at everything that's changed since last year, and this is just a list that is only scratching the surface of things that have changed for us dramatically over the last 18 months. And today it's a perfect example of some of the things that have come out of it, such as Zoom meetings and Google, and you're on mute, you forgot to mute yourself, and all these kind of things that we've now become accustomed to. Depending on which province you are, you've had to choose who you had to socialize with or had to not see because of your COVID bubbles. When it becomes in terms of your medical care, depending where you are, maybe you've been asked to not come to the hospital for your visits. Maybe you've been asked to do this by telemedicine. Where I work, it's usually done by phone, which means I haven't seen some patients over a year. I don't actually remember what their face looks like. And so I realized this recently, so I'm trying to bring them back to clinic so I can at least see them once in a while. And so this is sort of a good thing, bad thing. Some patients will appreciate not having to fight traffic and park at the hospital. Other patients actually like the relationship they have with their oncologist, which I can totally understand. Maybe you're one of those patients who had to been switched on their treatments. Maybe you're on immunotherapy and every 2 or 3 weeks, and now been asked to go every 4 or 6 weeks. And at the time, it seemed drastic and radical. And I think with some hindsight now, I think it was absolutely the right thing to do. We have some data that shows that it's not only safe, but it's equally as effective. So it's one of the things that probably will persist after COVID. And we've been hearing on the news, in Quebec, it's about how we don't have technicians for our radiology suites. We don't have enough nurses for our chemo suites. Getting blood tests for our patients is really a hassle. And these are the collateral damages that we'll probably be seeing and seeing more and more as time goes on. Probably in the next months and years, we'll really see the impact of COVID. Next slide. And when you walk outside, you're probably seeing all the signs of COVID around you. And one of the things is obviously everyone's wearing masks now. You're seeing plexiglasses in all the restaurants and stores. And we're talking about vaccine passports now. And so this really brings to what probably would be a big portion of my talk is about vaccines. And just so that people understand, I'm not going to berate people who haven't decided to get vaccinated yet. It's not the point of this presentation. Hopefully this presentation will encourage you, if you haven't been vaccinated, to get vaccinated. But certainly I think what I hope to do is to give you more information about the role of vaccines. Next slide. And the reason is that I think we're going to have to just start realizing we're going to have to live with COVID a little bit more. We're in the 4th wave. We don't know when the 4th wave is going to end, but now we know there's a 5th wave in Europe beginning. And you can only imagine all the variants that are around the world that are slowly going to creep into North America. So next slide. So when we look at COVID, I think we're going to have to start looking this as a disease that we're going to have to live with for a very long time. And I think when you look at experts, most experts are convinced that we're going to be talking about COVID as the same way we're going to talk about the flu and other viruses. So I think we're going to have to start getting that into our mindset, that we're going to have to get ready to start living with COVID as part of our natural and normal lives. Next slide. So as it pertains to lung cancer, and over the last year or so, we've been talking a lot about how COVID is very dangerous, particularly for lung cancer, and it makes sense. Lung cancer is a disease of the lung. COVID is a virus that can attack the lungs. So it's only natural to think that lung cancer patients are more at risk for COVID-related complications. But we didn't really have the data to back that up. And I'm not going to try and bore you with all the data that has come out. This is a snapshot. And I give credit really to all the researchers and doctors who really took the time to look at their patients and their patient data and come up with real information that can help us moving forward. And the answer is that yes, lung cancer patients do seem to be a bit more risk for COVID-related complications, but there are some asterisks that come with that. Next slide. and so this is one of the studies. It's the TerraVote study, which was a study that was headed by our esteemed colleagues in both in the States and in Italy and actually across the world, that looked at their patients who were touched by COVID and seeing what happens to them. So a couple of things that did come out, some factors that were associated with the COVID-related complications. So smoking history was one, but this really wasn't surprising because patients we know who have COPD are more at risk for the flu and flu-related complications. We knew that COVID was already going to be a little bit harder in patients who are a little bit older. And we know we have a lot of patients with lung cancer that are over 65. And obviously it makes sense that patients on chemotherapy, which actually reduce your immune system, would make you a bit more vulnerable. But what you didn't know is what was the effect of other treatments like immunotherapy and targeted therapy. And we had some provincial agencies thinking that immunotherapy was making you more at risk for COVID-related effects. And we actually are now happy to say that immunotherapy and targeted therapy are not associated with complications to COVID. Next slide. So if we're going to be living with COVID in the long term, what are we going to do, and how are we going to make it through it? And so this is a slide, actually, a data from Quebec about COVID-related deaths. And as you can see, last year in May, this was the first wave. We got hit pretty hard, particularly in long-term care facilities, and our hospitals were overloaded, like really. And it sort of went down and then went back up for the second wave. And then as you can see from spring of 2021 of this year, we actually didn't see any other waves really affect us majorly. And just a little click, I think my little slide there is there. Yeah, well, it was more in June, but we got a little crazy in Montreal and we started celebrating a little bit prematurely. But what you can see is that we didn't see any spike of COVID-related complications even after gatherings during the summer. So what was the cause of this? Next slide. Well, I think vaccines had a huge role, and I think particularly in Quebec, I can speak for Quebec, that we had a very aggressive vaccination campaign that's still ongoing to try and get as many people as vaccinated as possible. And with the studies that have come out from across the world, including places like Israel, which have been very paramount in giving us data about the safety of COVID vaccines, we've seen dramatic decreases in hospitalizations and ICU admissions. Of course, they didn't come without a hitch. There was, as you can imagine, a lot of press about, blood clots with COVID vaccines with AstraZeneca. We've seen some other issues with the mRNA-based vaccines with the heart. People were starting to wondering, well, should I get the AstraZeneca vaccine or should I get the Pfizer? And there was a lot of mixed messaging that I think was happening very early that sort of caused a lot of stumbles in terms of vaccinating the general population. But I think it's clear to us now that no matter what vaccine you're going to get, that there's overwhelming odds that you're going to get improved survival with these vaccines than if you don't. And I think that's the message from today. Next slide. And the other question was, well, how does it impact our lung cancer patients or cancer patients in general, those who are on chemotherapy or other therapies? Is the vaccine going to be safe? And we're lucky to have all these trials happening at the same time. This is the VOICE trial that actually looked at patients who are on either chemo or IO. and the reassuring thing is that most patients who get their 2 doses will have adequate protection from COVID. There is, of course, a small minority of patients who won't get the same level of protection as the general population. And these are the patients I think will greatly benefit from the third dose, which I'll touch on in the next few slides. But I think if there's one thing that came out of the study, and I hope is going to be reassuring, is that these vaccines are safe for cancer patients. Next slide. And talking about the third dose, the question is whether or not the COVID vaccine was going to be giving the permanent protection like the hepatitis vaccines, some of the measles vaccines that we have, or is it going to be like the flu vaccine, which you need in your annual booster shot? Next slide. And so these two studies, and I'm not going to bore you with all the slides and data, but what it shows is that your protection is pretty adequate after your second dose, but it starts to wane with time, and actually about 6 months, we think that your protection actually starts to decrease. And these are the time points where we think that a booster shot would be most appropriate. And when you look at each province, we know that now provinces are starting to get their booster shot programs underway, and depending on which province you live in, and I'm very sorry for those who live in the territories, I just didn't have enough space on the slide, but I rest assured that by looking at your territorial guidelines, it mirrors what we see in the other provinces. But depending on the province that you're in, you're going to have differing indications for booster shots. So if you're in BC, lucky for you, by next year, almost every adult will be able to get their booster shots. In other provinces, it's based on your age, and in the Maritimes, I don't think they're quite there yet. The other question is, who is immunocompromised? We think these are the patients who benefit the most from a booster shot, and this will also vary from province to province. And strangely enough, in most provinces, anyone on any systemic therapy, whether it's a pill for targeted therapy, whether it's immunotherapy or chemotherapy, and just by the way, I actually think that immunotherapy and targeted therapy doesn't make you immunocompromised, but that's just me. You are eligible for your third dose. In fact, the only place that isn't considering that is Quebec, where only patients on chemotherapy would be eligible, but I've managed to vaccinate my patients for the third dose regardless, just because I can. And just so you know that the booster shots, if you're on any of these treatments, are to be done not sooner than 4 weeks after your second dose, so 28 days or later, to get the maximal effect of your booster shot. Next. Oh, and I got a Stephanie who said that now the Nova Scotians, you are now in that list. And this is also a reminder, this is flu season. I know I'm supposed to talk about COVID, but let's talk about other things that are also involving vaccines. It's going to be potentially a rough year, considering that we didn't have really the flu season last year, and now a lot of the provinces are relaxing their restrictions. So we're anticipating potentially a rough flu season. So I do encourage you to get your flu shot. I think it's an added protection that is worthwhile. And yes, you can get your flu shot around the same time as your COVID shot. And I'm going to finish with another subject that I think is very appropriate and that doesn't really get the attention it deserves because it's mental health. And I know a lot of that was mentioned earlier on, and we're having a social worker also talk about some of the resources that I think are necessary. But I think mental health is something that always gets swept under the rug, and we usually deal with physical and disease-related stuff. But I think that this has as equally big impact on our lives as anything else. And we know, and just reading the press and all the articles based on how COVID is really being tough on our mental health, both in terms of depression, anxiety, social isolation, all that is becoming more and more apparent as time goes by. Next slide. But it's even harder for those with lung cancer. And the reason is because you're already dealing with the diagnosis of lung cancer, the treatments related to lung cancer, all the stuff that I talked about in terms of getting your test, which is already pretty tough. And when you look at all the studies and stuff coming out, and I was talking with Christina before, and I'm sorry that we actually did a lot of stuff with Lung Cancer Canada, not me, but other people who were able to do surveys looking at how Canadians with lung cancer are feeling through COVID, and it's quite apparent that the level of anxiety is at an all-time high. And depending on where you live as well, some of the restrictions in terms of isolation has increased the burden of anxiety in patients not being able to go see people. I have one patient whose only joy was traveling, and now he can't travel, so he feels quite depressed because that was his really one pleasure in life, and that's been taken away from him, at least until recently. So these are the kinds of things that weigh upon us as much as the physical aspects of COVID. Next slide. So what can you do? And this is not a list that I invented. This is actually a combination of different stuff that from different agencies, and actually individual provinces have actually made it a point to mention that anxiety is an issue with COVID. And if you look on the LCC website, or if you go on to the Canadian Cancer Society, there are also sites dealing with stress and anxiety and COVID. And I think these are resources that we should probably look at more. But I think the basic things about staying in touch with people, getting connected. If you can't see them in person, well, events like these I think are perfect. If you're not comfortable, and I have one patient who's very uncomfortable talking about her feelings with her loved ones, well, we put her in touch with a psychologist, which I know unfortunately is not available in every center. But at the very least, talk to your medical team. We're there to help. We're not there just to prescribe. We're there to listen. It's not always obvious, but we're there to help you in any way, shape, or form. And the last point, and you're probably wondering why I have a little guy dancing at the jig. Just laughing and humor is probably the easiest cure to anything. And I like Scrubs. It's my favorite television show, and for some reason Facebook seems to know that, so they send me little links that I click on, like clickbait, and I get a laugh, and it helps me get through my day a little bit easier. So whatever we can to laugh, I think it's always a good thing. So next slide. So this is my last slide. I won't belabor the point. I think COVID is here to stay, unfortunately, but I think how we get through it really depends on how we're able to adjust and how we're able to compensate for all the things that get thrown our way. And yes, vaccination is going to be a big part of the solution. It's not the only thing, obviously. And again, if you're one of those people who are still hesitant about vaccines, that's okay. I think it's your right, and I'm hoping that I will convince you otherwise today. And for the last point, obviously, in terms of the burden of the anxiety and depression that we don't talk about enough, it's not easy, and I can tell you that men are the worst at it. That it's important to keep connected with people around you, and especially your loved ones, because you need to know you're not alone, and that's important. And with that, I will stop.
Thank you, Dr. Zhao. And we know COVID has been very, very difficult for many, many people, and it is very important for that laugh. And for those of you that know me, I'm a very big hugger, so I'm going to send everyone here a virtual hug. And at this point, I'm going to invite Dr. Wheatley Price and Dr. Snow and Dr. Zhao back onto the screen for some questions and answers. If I can ask Darcy, please, to stop sharing the screen so we can see our panelists. So I think there is a question in the chat here, and some compliments to Dr. Zhao for his beautiful children. But a quick question to Dr. Zhao. Radiation wasn't mentioned. Does radiation to the lungs increase the chance of increased COVID severity?
So actually that I didn't mention it because I just forgot, but it was looked at in a lot of the studies, and it wasn't associated particularly with COVID related complications. And it's actually good to know because we've had issues with our radiation partners who felt that it was something that may have been an issue, and that some patients didn't get the radiation that they should have just based on that. And that's why I think it's always important that when you make policy decisions that is based on fact, although I would say that COVID was something that was thrust upon us quite suddenly, and we were all trying to make the best decisions possible. So I don't blame the people who made those decisions, but I think in retrospect, I think we come out with a sense that a lot of our treatments aren't deleterious in terms of COVID-related effects.
And Dr. Wheatley Price, there's a question in the chat about Lorlatinib and its status and coverage in Canada.
Right. Good question. So lorlatinib is an ALK drug. So ALK lung cancer is about 3% of lung cancers, and there are a number of ALK drugs targeted. So this is targeted therapies we're talking about. The original one that people might have heard of was crizotinib, and then there's been a number of new ones, Ceritinib, alectinib, which has become the new sort of standard treatment to start with. Brigatinib, which made its way through the approval system this year as well, and lorlatinib. So the thing about lorlatinib is there's some good and bad news about this, I'm afraid. Lorlatinib is the drug that many oncologists we want to use if a previous ALK drug has stopped working. So as what we call a second line treatment. And that has not been approved in Canada. And that has been frustrating. And despite multiple appeals and advocacy to try and get it available. Lorlatinib, however, does look like it might be a really good option as the first up treatment. It may be as good as alectinib or brigatinib, which are those are the three probably best ones to be given as a first treatment. And so it is working its way through the regulatory process for the first line. So there's good and bad to that. So the good thing is we might have access to all of the best options to pick from for somebody who's newly been diagnosed. The bad news is we might have lots of options to give as a first one and then none to give as a second one. So that's a little disappointing. It is a frustration for many of us. We are working on that. I can assure you that nationally and in provinces, we're pushing hard to try and get lorlatinib available in multiple places.
And if I may add to that, patient voices really do make a difference when we go to make these submissions for public coverage. So when we make the call out, and if you have experience with the treatment, please do answer and share your stories, because it has really changed the outcome of the reimbursement decisions. So we have lots of questions coming in the chat, and I'm going to direct the next question to the whole panel, but maybe we can start with Dr. Snow. Is there anything new available for people who had stage 4 non-small cell lung cancer who've already exhausted chemo, radiation, and nivolumab?
So a lot of our focus on the newest research is looking at the curative intent setting. We heard Dr. Wheatley Price talk about some of the new adjuvant therapies, and often we're refining what we do in the first line setting for those with with advanced cancer. And so for those patients who've already been kind of through those standard treatments, that's not usually the active areas that we see, but there is some interesting research going on in earlier stages of research. So not the kind of thing that will necessarily change what we have available, what we use in the clinic tomorrow, but some of that earlier stage research we often talk about phase 1 or phase 2. For instance, we saw some new interesting drugs where they're given with immunotherapy in patients who've previously progressed on immunotherapy, and then seeing responses come back. And a lot of the research is looking at why people become resistant to therapies that worked in the past, and saying instead of directly focusing on the cancer, focusing on the whole body of the host, and can we change the environment in which this immune system is working? In Montreal, there's a lot of research going on what we call the microbiome, which is the makeup of the natural bacteria we have in our body, which as we learn more and more about, we start to understand has a major impact on how drugs like immunotherapy work. So those trials are ongoing. I don't expect that it's going to change things immediately, but certainly if you're in an area where you have access to trials, and Dr. Ho is going to talk about that a little bit later, there may be things available for you to access it that you can't get through the normal standard of care avenues.
Okay, so we have a number of questions in the chat, and I want to be able to give everybody a break before we come back for our next session. So I'm going to ask the next session several questions rapid fire. And so if I can ask our panelists, please, to limit their answers to very, very short answers as much as possible. That would allow me to go through in the next 2 minutes the rest of the questions. So we have a question, and I'm going to direct this one to Dr. Zhao. Lung cancer and the risk of COVID-19 following being double vaccinated.
So just a point that I didn't make clear is that COVID-19 vaccines don't prevent you from getting another infection. It actually just reduces the risks of hospitalization and severe disease. So you can get COVID even if you've been vaccinated. And the other thing is that obviously the protection isn't 100%, especially if you're further down in terms of your vaccination, if you've been vaccinated over 6 months ago. So there's a risk. That's why there's an interest in booster shots. But what we can say is that those patients who do get COVID after their vaccines usually have very mild disease, if not at all. So that's the kind of at least proof that vaccines do work.
Okay, so Dr. Wheatley Price, CCO lung cancer screening sites expansion.
Yeah, I saw that question. Sorry, I should have checked before starting this presentation. Briefly, screening started in Ottawa, Toronto, North Bay, and Oshawa. And I don't know, actually, I can't tell you exactly how far it's being expanded. Ontario Health, when they announced it, said it would be a gradual expansion. Great opportunity to put pressure locally where you are to say, why is it not in Southwest Ontario, for example? And we'll do the same for you.
Okay, Dr. Snow, you get the last question. And do you think biomarker testing will be available for stage 1 patients?
So the availability of biomarker testing is very variable, not just based on your province, but which center you are in that province. In some centers, like here in Nova Scotia, we do reflex testing for biomarkers on all lung cancers, regardless of stage. Whereas in other places, it's limited to earlier stage cancers. But one of the key things is that we now know that Osimertinib plays a role in the adjuvant setting, and that data does include the stage 1B patients. So I expect that that will be more widely tested across Canada, as it does have a direct treatment implication in the future.
Thank you. And so that was exactly 2 minutes. So excellent job to our panelists. And the last note in the chat is Maria just sharing her status. And so congratulations that it's working. We're really, really happy for you. And we're going to send you virtual hugs and sending virtual hugs to everyone while we go on break. If I can ask my Lung Cancer Canada colleagues, please, to put 7 minutes on our timer so that everybody comes back sharply at 7 p.m. Welcome back, everyone. And we're going to go into the second half of our presentation now, and the second half of the evening. And really, we're going to start the evening by a topic that I hope that you got a little bit of this as we went into the break, and that's how exercise can change your quality of life. And to talk about this topic is a gentleman by the name of Manuel. Manuel is a PhD candidate at the Health and Wellness Lab within the University of Calgary, Faculty of Kinesiology, and he works as an exercise instructor and researcher with adults affected by cancer. So I think Manuel is going to get us up and moving. Is that right, Manuel?
We'll do a little bit of movement, yeah.
So over to you, Manuel.
All righty, well, let's get to it. Welcome, everyone. And first of all, thank you for having me. It's awesome to see such a great turnout and even to see some familiar faces. I see a couple of our participants through the crowd here. We've got Terry, we've got Angus, a few people across Canada. So it's great to see all of you. And today it's great to talk a little bit about the value of exercise for you and the value of exercise for those with lung cancer. We also have one of our patient partners with us today, who's one of our long-term class participants, Dwayne. So I will introduce him and he's going to speak briefly about his experience just at the end. So let me share my screen here and hopefully this works. I'm going to share my presentation slides and then we'll get going from there. So we will do a little bit of movement, but we'll do that just in the next after 15 minutes or so, because we just had a little break. So as Christina said, we're going to talk a little bit about exercise for individuals living with and beyond lung cancer today. So just before I get going, I do want to acknowledge that I do live and work on the traditional unceded territories of a variety of First Nations here in Calgary, where I'm working from. So before we start going into this, one of the important things that we always highlight is there's really strong evidence in the research and in practice that exercise is both safe and beneficial for all those living with cancer, including lung cancer. And this applies across the entire cancer continuum. So this applies anywhere from pre-treatment. We have an area of exercise called prehabilitation, so building up people's fitness and well-being before treatment, into treatment, post-treatment, and then into survivorship as well as advanced cancer care. So some of the exercise benefits are going to be listed on this slide, and I don't want you to get overwhelmed, but there's going to be a lot here looking at the different negative effects that cancer might have on you during treatment, after treatment, before treatment. So if you look through this list, maybe you can associate with one or two of them or more than that. Things like changes in body composition, weight management, fatigue, bone strength or muscle loss, depression, anxiety, some of those more mental health related things. And then down at the bottom, we have quality of life. So this is one that really encompasses and touches on and is affected by a lot of the ones above as well. And the cool thing about it here in our research that we do on exercise and cancer is that PA, or physical activity, positively affects. So it really counteracts a lot of these negative effects from cancer and its treatment. So all of those things listed there on the left are going to be mirrored on the right, and being active and joining a physical activity program, or just doing simple things like walking around the house, getting up off the couch every once in a while, can positively affect a number of these different side effects or symptoms that you might be experiencing during your treatment, after treatment, and into the long-term care. There's also a lot of psychosocial or mental health benefits. So we had our previous speaker talk about it in relation to COVID-19 and some mental health problems and mental health deteriorating for a lot of people that are undergoing cancer treatment or working through that. So we know there's a lot of psychosocial benefits from being active as well. One of them is being able to gain some social support. So I'll talk about our exercise program specifically a little bit later, but people who exercise and do so in a group, maybe with a walking partner, maybe even with their pet, or maybe in a group exercise class, feel connected with others who might have similar experiences. And this is especially the case. And one of the big things about our exercise programs, or if you do an exercise oncology or cancer specific exercise program, there's also really strong evidence for things like depression and anxiety. So we know that exercising regularly for those with cancer can decrease depression, can decrease anxiety, and enhance overall emotional well-being. And then lastly, one of the things that's really important as well, we always hear this over and over again from people. They say that when they started exercising, they gained back a sense of control, they gained a sense of confidence. And this is something that's so motivating for us to hear. And this is a really important aspect of exercising, is that for people who are undergoing a lot of different cancer treatments, are really facing or really limiting a really difficult situation, getting that confidence back, getting the sense of control where they can say, I can do something to improve my well-being. I'm not waiting for the next appointment. I'm going out there, I'm doing something. And down here is just the title of a really excellent systematic review that looks on the impact of exercise on quality of life for adults with cancer. So one of the really most common symptoms across all cancers, and this includes in lung cancer, is fatigue or cancer-related fatigue, chronic fatigue, if it goes into that long-term setting. And this is something where exercise can have a really positive impact. So on the right here, you'll see this cycle, and we call it the cycle of fatigue, or the vicious cycle of fatigue, that's really can negatively impact and continue to debilitate adults living with cancer. So once you're fatigued, this tends to lead to sedentary behavior. So you're going to spend more time sitting, or maybe even you're bedridden, or for whatever reason, you're feeling tired. So you spend more time sitting, not being active. And then this leads to deconditioning. So you'll be less fit. You might have some muscle loss, other things going on. So muscle atrophy, in lay terms, is muscle loss. So a variety of different factors, and then those things can actually further increase fatigue. So you can see how this very quickly turns into quite a negative spiral of fatigue and increased deconditioning. And when we exercise, we can actually flip this cycle on its head and turn it into a positive thing. So if we flip this cycle around when we do exercise, so if you replace fatigue with energy and sedentary behavior with physical activity, you start to get into a positive feedback loop, where as soon as you start getting up and doing something, start moving, even if it's just a little bit, we can get some improved conditioning, some improved fitness. And we find that exercise actually energizes people. So we always do these studies, and before and after an exercise program, if we check in with just like a 1 to 10 energy scale, it's interesting to see that all across so many different programs, so many different people tend to feel more energized after completing, even if it's a difficult exercise program. So with that, I want to talk a little bit specifically about exercise in advanced lung cancer, because this is actually part of a research study that I led just a couple of years ago, at the end of 2019, start of 2020, right before everything shut down. We were actually able to recruit advanced lung cancer patients from the Tom Baker Cancer Center here in Calgary, and they participated in a once weekly tailored exercise program within our unit. And they also had some nutritional support and palliative symptom management support. And this photo here is of Dwayne actually smiling, loving his exercise program. And it's a great testament that he's actually here to share with us a little bit about his experience in this program, as well as a further program that he took with us. So the NPAL program, which stands for Exercise, Nutrition, and Palliative Care, or Palliative Symptom Management in Advanced Lung Cancer, recruited 10 adults to do a 12-week intervention that included these components of nutrition, physical activity, and palliative symptom management. And each of these components was really tailored with experts to the individual to meet their needs, and as we always say, to meet them where they're at. And we had some really amazing results with this. This was a smaller study and more focused on the feasibility. So trying to understand, can people, even in advanced lung cancer, do this exercise? Can they complete this intervention? So we found the assessment and the intervention were highly feasible, meaning that people could get through the exercise sessions, no problem, complete those 12 weeks. And we saw some potential benefits to activity levels, well-being, and symptoms. But one of the things that always to me speaks even more powerfully than the numbers we gather and those quantitative data that we gather is the participants' voices. So we always try to gather this using interviews. And there's some great little quotes and snippets here from our participants. Things like, it somehow made me realize that exercise is a better treatment to the side effects that I have from my medication. Or things like, it caused my quality of life to be better, which really clearly illustrates some of those positive impacts from the program. And then the last one here, saying that I think it's definitely the thing that helped get you back to feeling your normal self again, which is something that I know a lot of people value. And that's something that people can take away from an exercise program, gaining control, gaining confidence, and feeling a little bit more normal, a little bit more like they can do something. And I know Dwayne's going to talk about that a little bit more, so I'm not going to steal his thunder. So with that, before we move into talking about some of our programs and doing a little bit of movement, I'm going to speak a little bit about a summary of evidence. So what the research shows in general in a broader sense, as well as some of the cancer exercise guidelines. So you may or may not have known this, but there's actually very specific guidelines that have been put out in terms of exercise for adults with cancer. And these really show us where the evidence is at and show us that there's really strong evidence to have these recommendations come out. So some of the points here that I highlighted on this slide, first of all, we know from research that exercise is both safe and feasible during treatment, meaning that people don't go through any adverse events, generally speaking, and they can exercise during treatment. It can improve physical functioning, fatigue, quality of life, mental health, a number of different factors. And during treatment, we tend to recommend people to avoid inactivity and then return to normal daily activities, so what they were doing from before, or return to being active in daily life as soon as possible following their diagnosis. After treatment, these guidelines show that exercise is an essential component for recovery and regaining fitness. So it can improve a lot of the physical side effects people are experiencing. And there's growing evidence for a number of different side effects, including fatigue, including quality of life, but including some smaller things, things around pain and other side effects as well, lymphedema and breast cancer, shortness of breath and lung cancer, things of that nature. And we know that exercise tends to enhance overall well-being and quality of life, which is exactly what we tended to see in our NPAL program. Lastly, and I always like to highlight this point, I don't want to skip over it. We know that individualizing and tailoring is necessary. So just as treatments are getting more and more tailored and specific and personalized based on different mutations, based on different biomarkers, and in that sense, getting more effective, exercise treatment also needs to be individualized and tailored. So we need to think about basic things such as the people's fitness levels. Where were they at before? What were they doing to be active? Their gender, age, disease status. Are they on treatment? Are they not on treatment? We need to think about what is their social support? Do they have enough support to make this program realistic, feasible? Do they have someone that can support them to get to the exercise center, and so on? And then thinking about access to resources, programs, their exercise preferences. So have they done something before? Is there something they like to do or something they don't like to do? And then considering their barriers as well. So we never want to ignore the fact that beyond the cancer and the treatment and so many other factors, there's a lot of things that make it difficult for people with cancer, actually for anyone to exercise, but these barriers are added on top of a number of cancer-specific barriers as well. So we want to be considerate of that, and we need to tailor to work around that or to address those barriers. Otherwise, if there's too many barriers and not enough conditions that facilitate people being able to be active, we're not going to be able to be active. We're not going to be able to get patients active or people to realize these benefits of exercise. So with that, I want to briefly go through this. I don't want to overemphasize it, but these are the recommendations from the Cancer Exercise Guidelines, which were published in 2019 or updated in 2019. So in terms of aerobics, so this would be cardiovascular training, things like walking, running, biking, of that nature. They recommend 90 minutes of moderate intensity aerobic exercise per week. So moderate intensity would be something that does get your heart rate up, does get you working relatively hard, but not something where you're completely exhausted, not something that really pushes you to be sweating like crazy or feeling super tired afterwards. And then strength training. So 2 days of strength training are recommended per week, as well as flexibility training on most days of the week. So as you can see, a pretty comprehensive recommendation. But the important thing we always come back to is some of our key messages around movement. So while these exercise guidelines exist, it's important to recognize that people are not always going to get there right away. And it's not always important to overemphasize, are you doing 90 minutes or not? Because it's not a black and white sort of thing. The key message we always emphasize is to move more. So if someone hasn't been doing any movement, we want to celebrate the fact that maybe they're getting up and doing 5-10 minutes per day, or even 30 minutes a week of movement within their day, things that they can do. We always like to emphasize, do what you can and do what you like. So different people prefer different types of exercise. Different people have different abilities and past histories. And maybe if you have other conditions that prevent you from doing one thing or another, we can always find ways to get you moving and find ways to support you doing what you can. With that, within all of our programs and throughout, a really important thing is to listen to your body. So you know yourself best and you know how you're responding to exercise. So if you feel really, really tired, if you feel that extreme shortness of breath, we encourage you to sit down, take a breather, and so on. And you're really your best moderator for exercise. The second one here, and this goes back to getting social support or feeling supported, is we know that social support, having people that support your movement habit, is essential. So we encourage people to find your support or find their support for active living. So doing things like getting active with family or friends, joining an online group-based activity program, and I'll share some options for all of you for that in a little bit, are ways to gain social support, and then considering potential barriers. So thinking about what you enjoy, but also thinking about what might be accessible, what's realistic within your other commitments in terms of time, what's something that's sustainable. So finding a habit that you're going to enjoy, but something that you'll be able to maintain over time. So sometimes people get too focused on these 90 minutes or the Canadian guidelines of 150 minutes, and they really go all out for 2 weeks and they just become completely exhausted. And after that, they hate exercise. They didn't have a really positive experience. And then that's not a sustainable way, because that's going to lead actually in long term to more sedentary behavior and inactivity than it is to a sustainable movement habit. So with that, before we move on to talk about some of our exercise oncology resources that we have through the lab, I want to do a quick 1 minute of movement. So if you're feeling up for it, if you're feeling good for it, we're going to do a little bit of movement together real quick. I'm going to tilt my screen down here. Hopefully you can see me a little bit. But what we're going to do is called sit to stands. So this is just finding a chair behind us, finding a couch behind us, or you can do squats if you know how to do those. But we're just going to sit up and down off that couch or that chair 10 times. So do whatever you can, do whatever feels good. If you do 5, that's good as well. I'm going to count to 10 on my own, but you are your own accountability. So do whatever you can. If you don't want to do that sit to stand, you can just do some arm circles, do some big rotations, shake your legs out a little bit. I already lost count here, but I'm probably around 5 by now. We're going to do 5 more. And it's going to be a great movement break here, and really shows that you can do movement in your everyday life. You can incorporate it and make it a habit. So here we go. We're at 10. I'm going to shake my legs out at my standing position here and come back to everyone. So thanks to those of you who are able to move with me, and hopefully you're feeling good, feeling a little bit energized by that movement. So with that, I see our time here. We've got about 10 minutes left. So I'm going to go through some of our exercise oncology resources. I'm going to tell you a little bit about some of the projects that we have, most of which are research-based, but we offer a ton of really great free resources and free programs to people just like you across Canada to be able to access and join. So here, what are our exercise oncology programs? So our exercise oncology programs are available for all adults living with and beyond cancer across Canada. And most of the time they include a free 12-week group-based, and I put tailored in here because all the programs, while they're group-based, are still individualized, they're still tailored to you, exercise programs. These programs are always, and this is something that we always emphasize, safety, the fact that we need really qualified people to work with these cancer populations. So by trained exercise oncology professionals, these people undergo really specific exercise specific training, but also cancer specific training. So they learn about the basics of what cancer looks like, what are different limitations and symptoms and ways to work around those in terms of exercise. And then right now, but this might be changing again in the future, all of our programs are delivered online via Zoom, and Dwayne can talk a little bit about those experiences of doing an exercise program on Zoom with a group of other people with cancer. So we have 2 different major programs and research programs. The first is the Alberta Cancer Exercise Program, which is for patients that live in major urban areas in Alberta. And this is really what built our success. So Alberta Cancer Exercise has been around 4 or 5 years now, and it's reached over 2,500 people living with and beyond cancer of all kinds of cancer types across Alberta. And from that, we developed the EXCEL program. So EXCEL stands for Exercise for Cancer to Enhance Living Well. And this is for patients that live in rural or underserved areas in Canada. So the aim of Project EXCEL, building on ACE, was really to reach these populations that didn't have access to any of these kind of cancer-specific exercise programs. We want to make sure that that access is opened up. And this means anyone that doesn't live super close to an exercise oncology program, or lives, even if they live 45 minutes or an hour outside of Toronto or another area, they can participate in Excel. And both of these are free 12-week programs. They're available to anyone who's either before, on, or post-treatment, and within 3 years of completing treatment. And now, importantly, if you still have ongoing side effects or ongoing considerations, complications with your cancer, you can be eligible beyond these 3 years. So don't worry if you say, oh, it's been 4 years, but if you still have that chronic fatigue or something else, you can still join our programs. And all of our programs start on a 12-weekly basis. So in January 2022 is when we'll be starting our new programs. And we'd love to welcome some of you to those programs. So if you're interested, you would be emailing wellnesslab@ucalgary.ca. That's our lab email address. And then our coordinators for those programs would work with you to go through some basic safety screening. If needed, they would go back to your oncologist and ask for some additional information or approval. And then we would get you into our exercise programs. Now, the exercise program looks like this. As I said, 12 weeks of group-based exercise. We meet twice a week for 1 hour each. And since we have a number of different classes, we have classes that run in the mornings, in the afternoons, in the evenings, and across Canada in different time zones. And so wherever you are, you would be able to find something that fits for you. They are circuit style, but they are tailored to individual needs. So for each exercise we offer different options. We allow you the possibility to do things your own way and to find maybe an easier or a harder option to find the right level for you. And all of them are run on Zoom, but we have a lot of things that we do to ensure safety. So while we have an instructor, we always have a moderator who's a separate set of eyes who's completely just looking for safety, ensuring that we can see you on screen and working with you to ensure you're safe. And these are just some common questions that people have asked about whether exercise is right for them or these programs. And the thing here, the common theme that's highlighted in the middle is that we always meet you where you're at. So this is dependent on your previous experience, your current fitness, the equipment you have available, and we can always modify and tailor that program based on your needs. So we have people that have done our whole program that are chair bound, that have done it all seated. And we have people that used to be marathon runners that are coming into our programs and looking to really get back on their feet. So with that, I'm going to skip through these quotes because I want to give Dwayne a chance to talk. So Dwayne, you're welcome. I'm going to stop my share screen and we can spotlight Dwayne. He's one of our program participants, and he can share a little bit about his experience of joining our exercise oncology programs and what he's gotten out of that.
Thank you. First of all, just kind of set the context. I'm a non-smoker with stage 4 lung cancer, diagnosed in the summer of 2019. I was on Afatinib for 9 months, and I've been on Tagrisso for 18 months now. When I started the first exercise program, my wife delivered me to the nearest door because we weren't sure I could walk from the other side of the parking lot. At the end of the 12 weeks, I was using my treadmill at home regularly, going 3.5 miles an hour for 30 minutes. So they took me from somebody who had no idea what any of the terminology was, or how to perform any of the exercises, to being actually able to do quite a bit. The instructors were marvelous. Then COVID hit at the end of the 12 weeks. So things paused for a while. But in the fall of 2020, I started in with the Excel program. And since then, I've done the Excel maintenance, which is the follow-on programs, continuously. I've gone from being afraid of trying to exercise because I wasn't sure if I'd be able to being very, very actively looking for things to do, understanding the limitations I have, and remembering some of the things the instructors have said, some of which Manny iterated a couple of times, but listen to your body, take a break, adjust it at your own speed. And I'll add to his comment about tailoring. The instructors that I've had, and I've had quite a few now, are all really good at offering alternatives. If you want to do a particular exercise or exercise a particular part of the body, they've got a main one, but they talk about and demonstrate alternatives. Almost anybody can do almost any of the exercises that are we go through. Sorry, I need to add one more comment. When you took the break there and wanted us to do squats, that I couldn't have done a squat 2 years ago. I'd never done a squat. That's the level that I've come from, and it's been really good for me. I think that's the key message. But many you have talked to me many times. Is there something I've left out?
No, that sounds great. Yeah, it's always great to hear from you and hear that testament. And yeah, Dwayne came through several of our exercise programs, and it's really great to see from that first assessment to where you're at now. We love to see your confidence and your ability to tackle movement rather than be afraid of it.
I did leave out something. It isn't just a physical process. There really is a social, but more for me, a psychological process. I have gone from not wanting to do anything, really sitting back and trying to avoid things, to actively getting involved with things again.
Great. Yeah, awesome. Thanks for sharing, Dwayne. Yeah, hopefully you're all encouraged to try out some movement, and encouraged to see Dwayne's story and other people's story that you can move and you can get some of those benefits from exercise. So yeah, if you're interested in any of our programs, please contact us. But we also have a lot of other resources available to support you in doing movement your way. So thanks for having me today, and look forward to questions later, but I'll pass it on to the next speaker here on time.
Thank you so much, Manny, and thank you so much, Dwayne, for sharing. I think my plan after this event tonight was actually to go and get some ice cream, but maybe I'll need to go and step onto the a bike for a few minutes before I do that. Our next speaker tonight is Dr. Cheryl Ho. Dr. Ho is somebody that is very familiar to Lung Cancer Canada, and besides being mom extraordinaire, she also is one of the co-chairs of one of Canada's premier lung cancer conferences, the Canadian Lung Cancer Conference. And so Dr. Ho tonight is going to talk to us about clinical trials and how to get involved in clinical trials. She's a medical oncologist at the BC Cancer and clinical associate professor at the University of British Columbia. She's also part of our board of directors and also on our medical advisory committee. So I'm going to turn it over to you now, Dr. Ho.
Great, thanks, Christina. Welcome to everybody. As others have mentioned, to the evening. It's been great to hear everybody else's story, and just by way of example, Manny's presentation highlighted how actually clinical trials, not necessarily related to treatment, but potentially other aspects like exercise can be applied for patients with lung cancer or cancer in general. Next slide, please. So for this brief talk, I thought I would highlight a few things that are important when thinking about participating in clinical trials, the rationale and the types of clinical trials that are available, providing some reliable resources, which I think I saw in the chat somebody had asked questions about, and talk about a few myths around cancer research. Next slide, please. So I think to frame what we're talking about in terms of clinical trials that involves treatment, that the process is actually really quite long. Before anything actually makes it to the clinical trial aspect, there's been a lot of research or background done beforehand, starting in the lab, then doing experiments in cell culture, moving to animal models before it actually moves to the consideration of the treatment phase. Next slide. And this is an old reference, and I apologize for that. It was kind of combined two pieces of information that I wanted to share. One was just thinking about clinical trials and drugs that are available and how many actually make it to the point where we think about getting some kind of regulatory approval by either the FDA, which is what this slide references, or Health Canada in Canada, for example. And that there are thousands of drugs that are developed in that preclinical phase before we're actually thinking about even moving to looking at experiments and cell cultures and people that never make it anywhere. So, they estimate in terms of 5,000 or thousands of drug candidates for one that actually gets approved. The second piece that I thought was interesting about this graph was actually the amount of time it takes to get a drug from that development phase to actually getting a regulatory approval. This study, again, being old, was 12 years. And if you look at more recent statistics, it's about 8 years for that process. So really, it is a very long time to ensure, of course, that drugs are safe and effective before we actually get approvals. Next slide. And as mentioned from Manny's talk, which has been really helpful to highlight that, clinical trials can test many different kinds of things. It can look at finding and diagnosing cancer, as Dr. Wheatley Price had talked about with reference to lung cancer screening. That's how many provinces actually got screening in the first place, from cancer prevention, or even management of cancer and treatment side effects, as well as trials that are involved in treating cancer. And that's mainly the focus of the rest of what I wanted to chat about. Next slide. So when we're looking at clinical trials that involve treatment, there are typically 3 phases of clinical trials. And the first is a phase 1 study. And that is a type of study where it's been established that the drug potentially has a reasonable mechanism of action. And now we want to actually see if this is potentially helpful to people. So the biggest goal is really kind of looking at safety for these new therapies and figuring out how a new drug should be delivered. So should it be intravenous? Should it be oral? Once a week, once every 3 weeks, and what kind of dose? All those things are worked out in this aspect. So the number of people that are involved in a phase 1 trial is actually pretty small, in the range of 15 to 30. Next slide. In phase 2, this is where a drug that has been shown some promise in the phase 1 studies, it's safe, but it also shows a signal that it may be effective, is actually moved out into bigger studies. And what we want to determine is whether the new treatment actually can change or have an effect on the cancer itself. And oftentimes when a phase 2 study is done, the questions are being asked of, how well does a cancer respond or shrink with this treatment, or how long is it controlled with this new treatment? And these types of studies involve a little bit more participants, usually in the range of 100 or less patients would be involved in a phase 2 study. Next slide. In phase 3, this is the point where I think a drug that has shown promise in phase 2 is now being tested in a larger population. And the big question that we're asking here is this new treatment as good as or better than the old treatments that we currently have? And this aspect of a phase 3 trial is really critical because this is the piece that enables regulatory bodies like the FDA or Health Canada to make decisions about whether a drug should be available in respective countries. And also for us in Canada is also the piece that helps us establish the added value of a new treatment to the treatment algorithms and how that will go through our national process for our drug approvals. Next slide. So if you are considering a clinical trial, there are critical pieces that you receive from your medical oncologist or oncologist in general to kind of give you information about that study. And for people who are participating in the study, that's the study consent. For investigators that are running the study, that is called the study protocol. They have really the same components, but just different kind of languages and perhaps outlining, in more detail, the study protocol for us to ensure that we're running a clinical trial appropriately and safely. But that study consent has some pretty critical components for patients to understand, patients and their families to understand the potential treatment. So of course, there is the reason for doing the trial, outlining who can join the trial, and that's called eligibility criteria. How many people are planned to be enrolled in that study in your center as well as internationally? What the drug and treatments are, how they'll be given, what the dose is, what are the known side effects based on the studies to date, the type of tests that are going to be involved, and the type of information that's actually going to be collected. Next slide. And so when kind of going through this, I've had a number of questions from my patients just about kind of different criteria that are involved in studies. And one of them is about why are eligibility criteria so strict? And the main reason why is safety. Because sometimes we know that new treatments may have certain side effects that could have an increased risk for people with certain medical conditions. So they may not be invited to participate. And it also includes tests to understand what people's baseline medical status is before participating. So again, that we can ensure that people stay safe. And the other piece is, of course, that the results need to be accurate and meaningful. And this is that other piece, where we're thinking about these treatment options as new opportunities, we also have to put it in the context of the other people that look at these studies, like the FDA and Health Canada, and make decisions based on them. So we have to be able to ensure for those types of bodies that we produce the right kind of evidence so that they can move forward and approve these drugs so we can access them. Next slide. The other question I often get is, why are there so many tests involved in a study? And I think, again, that speaks to that safety piece. So while we often, depending on what phase of study it is, we may have some safety data available, we don't know as well as the side effects as well as perhaps something we would commonly use, like Tylenol or other therapies that we've been using for a really long time. So we need to ensure that we're delivering this as safely as possible and that we are mindful of potential side effects that could arise and catch them early. The other piece, of course, is we want to make sure that the treatment is working, because if the treatment is not working or not beneficial, then of course we would like to look at other treatment opportunities, and ensuring that we capture that early so we can offer those other opportunities is really important. Next slide. The other aspect is, why are some treatments available in Ontario and not BC? And I think this is just a constellation of a number of different factors, a lot of different influences in which trials are actually open in the center, ranging from the pharmaceutical company to the institution, as well as the investigator and the study team and patients. I think the one advantageous thing about our healthcare system is that you can participate in a clinical trial anywhere in the country and have that funded or covered by the healthcare system. It is a little bit more challenging to go to the States to do trials. Some of my patients ought to do that, but there's a lot more logistics and hoops to jump through, but again, totally feasible. But I think when I talk to people about clinical trials, I both have my eye on what's available locally, but also what's available nationally, depending on where the rest of their family is or other opportunities that might be suitable for them across the country. Of course, that's changed with COVID, but hopefully we'll be able to go back to that state again. Next slide. And I think that it's really important to look at reliable resources for clinical trials. So I've listed a few Canadian ones as well. So the Canadian Cancer Trials, the CTG, which is the Canadian Clinical Trials Group, which is based out of Queens, 3CTN, and then all clinical trials are required to be registered on clinicaltrials.gov. It's just part of the mandate, so you can certainly look there. The hard part is knowing which studies are actually open and available to enroll patients, and which, because things move so quickly in this environment. So, you know, if there's a study that my patients are interested in, and I usually just touch base with the investigator to kind of ask, is this feasible? What are the timelines looking like? How's the accrual been going so far to date? Just to really get that in the moment understanding of whether a trial's opportunity is truly there for some of my patients. Next slide. So I just wanted to cover a few quick myths about clinical trials and hopefully debunk them. The first myth is that clinical trials participants are human guinea pigs. And I think from my first slides, you certainly could see that investigational medications are really researched for quite a long time in advance before we actually move those therapies for consideration of treating patients. It is true that we don't know everything about the side effects and the efficacy about the new treatment. I mean, that's why they're an opportunity within the clinical trial. But we are really focused on ensuring that we try to deliver treatment as safely as possible, and there are strict scientific and ethical guidelines to make sure that we're offering clinical trials in a suitable fashion. Next slide. Another myth is that every clinical trial uses a placebo as a comparison, which is not always the case. Sometimes a clinical trial may take the new therapy and compare it to placebo, or it might compare it to another, for example, standard of care treatment that's available, like chemotherapy or immunotherapy. So it all depends on what kind of clinical trial is actually being run. And sometimes it's two active treatments with an added layer of a new therapy versus a placebo on a backbone of a standard treatment. The comparison group that doesn't get the investigational treatment is known as the control group. And so for the most part, the control group is meant to represent what would happen if we were doing normal clinical practice. Next slide. Another myth is that a clinical trial only helps people in the future, but it doesn't actually help, somebody participating in the actual moment. I think certainly as a medical oncologist, I see clinical trials as just opportunities, access to new therapies that I can offer my patients that have shown some kind of promise in some of the earlier studies. There's also evidence to say that people who do participate in clinical trials have outcomes that are at least as good or potentially better than other patients. So they, I think, are just really about providing an opportunity, and some of my patients just appreciate having the clinical trials team in the background to be able to support them through their care. Next slide. Another myth is that once you join a clinical trial, you can't change your mind, which is absolutely not true. I think we all make decisions in the moment, but sometimes that doesn't always apply as time goes on. And so people make lots of different decisions around what they want to do with their time and participation over time. So sometimes I've had people stop because other life events are happening, not necessarily related to them. Sometimes people become tired of the therapy and make choices to stop at that point as well. And other times there are other reasons that are involved. But at any point in a clinical trial, you can decide that you don't want to participate and just discuss that with your care team, just in case there's anything that can be changed to make it more feasible for you to continue to participate. But we recognize that, when everyone starts off with the best intentions, but real life sometimes just gets in the way, and that is totally fine. Next slide. Another myth is clinical trials are only a last resort. While it can be true for some people that it may be somebody who's tried lots of different therapies, and so then they're looking at trials as an option for treatment. But we have clinical trials in every phase. We've talked about screening, exercise, all of those aspects. So, it can be, you can be at any different point in the treatment trajectory, and depending on your institution, there would be opportunities across that whole spectrum that you may participate in. Next slide. I think the reality, rather than a myth, of clinical trials is that, we need them. New medications can't be approved by Health Canada and can't reach patients unless we actually run clinical trials. And this is just a graph looking actually at US statistics, so FDA approvals, showing that over the course of the past 60 years, that in the past couple of decades, we've had our best success in terms of approving new immunotherapies or targeted therapies, and even some chemotherapies for lung cancer patients, which I think holds a lot of promise for the future. Next slide. Thank you. And if you have any questions, I will let Christina moderate, is what I will do.
And thank you so much, Dr. Ho, and thank you so much for our Hope Army support for that program. I'm going to at this time invite Manny and Dwayne to come back on as well for questions. I see there's lots of questions in the chat, and we're going to take the next few minutes to go through them. I think one of the first questions that was on the list was really directed to Manny, and some of our listeners were saying that they had certain disabilities. One has even had a stroke. And so can they participate and can they join as well? And would this program be good for them?
Yes, certainly. So I sent a little private message to Marla, and we were just in touch, but certainly people with different limitations can also join our programs. All of our programs go through a screening process at the start with a qualified exercise professional. So actually a clinical exercise physiologist, which is kind of the highest level of exercise professional in Canada. And we accommodate all of those sort of things. So depending on what the limitations are, we usually can make that work regardless. So yes.
And I think, Dwayne, you can attest to the fact that, you know, if you don't need to run a marathon to start, and it really is doing what you can.
Exactly. The process of getting assessed to see if I was going to be allowed to go into the program or invited in was a really big deal for me. That's what actually started me understanding that I could do things.
And so, Manny, there's also a question about programs specifically designed for lung cancer patients.
Yes, I can speak to that. So I know Emmy really well, who has been advocating for some lung-specific programs. And this is certainly something that is, as long as we have the numbers there and we have enough people across Canada that are interested, that are available at the same time, we certainly want to offer some tumor-specific programs if the interest is there. So as long as the numbers are there, we're happy to offer it and we can accommodate it. Yeah.
So, Dr. Ho, there's some questions about the trial process and what happens to all the drugs that never make it to market. What's the major reason that these drugs fail? And do we sometimes go back and look at drugs that didn't work in the trial process and maybe they can be effective now?
That's a great question, Archie. I think so. One big factor that would eliminate a number of therapies is really toxicity, right? Side effects, and sort of what the influence that has, even in this sort of cell culture phase, right? What's actually feasible there. And then I think while you're aiming to potentially develop a new drug on target for example, a specific mechanism, you might not actually design that therapy in the correct fashion to address the particular pathway that you're looking at. So I think there's the efficacy piece, and then there's also the toxicity piece. But I do think that we go back sometimes, it kind of depends, I think a little bit, and look at some of these therapies, because if you think about how drugs get repurposed. There were some cancer drugs, for example, that were actually developed that actually been repurposed for lung fibrosis. So, I agree with you. Probably we need to be a little bit more broad thinking and laterally thinking instead of sort of down a specific pathway to enable us to maximize our benefit from those therapies.
And there's an additional question in the chat by Allison that Dr. Zhao started to answer, but I think it's worth bringing up to the bigger group here, is it the patient that initiates a discussion about clinical trials, or do physicians usually start the conversation?
And I think Dr. Zhao is totally correct. It goes really both ways. I mean, I am always happy to hear when patients tell me they're interested in participating in clinical trials, because even if we can't find an exact treatment clinical trial, there might be something else that might be appropriate in terms of sequencing or patient-reported outcomes or any kind of opportunities that are out there. But I think also when there are not established pathways for treatment or specific targeted therapies, these things are always kind of going on in the back of my mind to kind of offer opportunities for people to see how open or willing they might be to participate in those types of things as well.
For sure. And I will say that, I've met many of the advocates and patients and friends that are here tonight that have really had their life extended through clinical trials, and it's really been a lifeline for them, and it's really allowed them to live a really great quality of life. Emmy says to everybody here that if you're interested in joining a lung cancer specific exercise group, please put your name down, and we'll try to make that a reality. So I'm going to thank Manny, Dwayne, and Dr. Ho for their being on the panel of this portion of the evening. And that last picture of Dr. Ho that was on there really set us up very well for the next portion. I'm going to do a little bit of a showcase. Today is really the middle of Lung Cancer Awareness Month, but we've still got lots of activities planned. If I can have our next slide, please. Those of you who joined us at the last week, the 2021 State of the Union of Lung Cancer, our Faces of Lung Cancer report is posted on our website, and we'll be creating some pullouts as well as advocacy materials that you can use, and we'll be calling out to all of you if you should wish to either spread the awareness by posting it on your social media, or if you'd like to take a step further, take these action points into your MPs, elected officials, MLAs, MPPs, and help us turn some of these wishes that we have in the faces into reality. Next slide, please. As I said, that this is just the middle of the month, and we still have lots of activities on the go. December 1st, we have our webinar, our What's New series. It's the last in the year of What's New in Radiotherapy. And then December 5th is our Evening of Hope, and we have ongoing campaigns as well. Can I have the next slide, please? So we have a joint program on the go with the Lung Health Foundation called Asking the Wrong Question, and it is really something targeting anti-stigma. The next slide, please. So if any of you who were on the call last week, this is the time where I'm asking you a question. How many of us here believe that it is unfair that lung cancer patients are stigmatized? And how many of us here believe that lung cancer patients deserve a voice? If you agree that lung cancer patients deserve a voice, please go into your reactions and give me a thumbs up or give me a heart or a smiley face, because this, and then I'm going to ask you please to join Hope Army. Hope Army is a social media campaign and an awareness campaign that really talks about how and uses action to say that lung cancer patients deserve a voice. And we have our Give To Get To campaign, where we're going to send you these stickers, take them into your MLAs, take them into your friends, your family. I've got mine posted on my bullet journal here, but I think that we've got coast to coast representation here, where some people put them on their bumper stickers, and just really, it's that loud and clear indication that lung cancer patients do have a voice. Next slide, please. Our 2021 Evening of Hope is on Sunday, December the 5th from 6 to 8 p.m. Please join us. It is free for anyone to join. We ask for a suggested donation if you can. But for all lung cancer patients and their families, I want to see everyone here that has joined us tonight come and join us. And we will, in the name of wellness and some of that sharing that Dr. Zhao was speaking of, everyone that does join us is going to get a $30 gift card so that we can all share a meal together. And Dr. Wheatley Price says that his sticky toffee pudding recipe will be part of the evening as well. So anybody who wants to learn that recipe, please come and join us at our Evening of Hope. And Michelle, if I may ask if you can post the link to the website to sign up into the chat as well. It is now my pleasure to introduce the newest member of the Lung Cancer Canada team, and her name is Elizabeth Dverkstein-Bose. Elizabeth is a registered social worker from Winnipeg and has recently joined our team as the new social worker that is helping us to run the new Airways of Hope program. I'm going to pass it off to Elizabeth now to talk a little bit about the program and our LCC resources.
Thank you, Christina. Good evening, everyone. I'm assuming everybody can hear me, but if for some reason not, please jot that down in the chat quickly. So it's a pleasure to be here. Like I said, my name is Elizabeth Dverkstein-Bose. I'm the new social worker here at Lung Cancer Canada, and I'm really happy to be starting. So I am, like Christina said, I'm based here in Winnipeg, Treaty 1 territory in the homeland of the Métis Nation. I'm available virtually for anyone, though, across Canada. Oh, good. Thank you, Michelle. So I'm just going to give you a brief overview of some of the resources and supports available here at Lung Cancer Canada. We know that a lung cancer diagnosis impacts the physical health of a patient, but we also know that it can deeply impact the emotional, social, spiritual, and practical health and well-being of patients and the people around them. And Lung Cancer Canada is here to provide support. Next slide, please. Oh, that's it, actually. Go back, sorry, one. So the Airways of Hope program, which is the program that I'm a part of, really focuses on the psychosocial supports, interventions, and collaborations that really have a goal of enhancing the health and well-being of those impacted by lung cancer. So one of my roles specifically is to provide one-on-one support virtually to patients and families in a confidential and safe environment. And it's really an opportunity to receive emotional support, grief and bereavement support, to discuss practical and day-to-day and financial concerns that might come up. And it's also an opportunity to connect with other resources that might be available in the community or in a province or maybe even throughout Canada. And this one-on-one support can also be helpful in navigating social and healthcare systems that can sometimes be quite complex and challenging. Another really exciting support that's coming up in the new year is our national monthly group for patients, families, and caregivers. So if you're interested in something like that, please stay tuned because more information will be shared in the following weeks. Next slide, please. Oh, okay. We'll just maybe go back one more again. I was thinking it was patient stories. So part of our mission here at Lung Cancer Canada is to increase public awareness of lung cancer and to create space and opportunities for people to share their own personal stories. Thanks there. So on our website, on the page, on the main page, there's an orange icon that says patient stories. And if you go to that icon, it'll bring you to over 30 personal stories. And there's also a spot on the website where you're able to directly share your own personal story as well. So if you're interested in either of those types of resources and supports, please don't hesitate to check that out. And our peer-to-peer support network is another really excellent resource. It's an opportunity to connect with the volunteers who themselves are lung cancer survivors or family members or caregivers who have their own personal stories and have walked the lung cancer path. And their mentorship and encouragement and empathy and hope can really be a meaningful source of support. So if you're interested in any of these resources and supports, please don't hesitate to check out the website or to reach us directly, and we can get in touch and I'd be happy to connect. So thank you very much.
For anybody who wants to be connected to Elizabeth, please send us an email at the info to info, and we can certainly link you to Elizabeth. But I know that there is also desire for various regional groups to get together. So I know Tim and Emmy are hoping to get some Alberta activity going. Christine has some a group in Manitoba. We have a large group in Ottawa as well. And Angus is starting, has some activity in BC. So if anybody wants to also join some regional specific activities, please send us an email and we will be sure to connect you with the group within your region. So at this time, we are at 8 o'clock, and I just want to thank everyone for joining us, sharing, giving us your time today. It is very, very meaningful to us to have lung cancer patients and their families, and also our clinicians from right across the country, and be here with us for this National Patient Summit. If I can have the next slide, please. I'd like to take this time and thank all of our program sponsors that support us in many different ways. Next slide, please. At this time, we have the opportunity for breakout rooms. I'm going to ask that our pharmaceutical